missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribed members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up.
Oh. Good morning, good morning, good morning. Are we good? Yes, welcome, Brother Ryan. I don't know, I thought I have enough time to go up and down and still come back and find the videos running. Okay, so yeah, a warm welcome, colleagues. I hope you are good. I hope you are well. This is us. This is what we do every single morning of our Saturdays. But this month, I think we had at least one weekend where we didn't have anything. I don't know. I'll check what's happening next, but it's likely to be a busy month as well. Yeah, so welcome. I'm not going to do any slides. I think the intro videos and stuff have sort of showed us everything that we need to know. Let me just check and make sure that, oh, I was about to check if you are able to share your screen, Brother Ryan. Let me make you co-host. Colleagues, are you good? Are you good? Give us a sign. Bavich, Anika, many of us have, many colleagues have not yet joined, so I'm hoping they will join as we continue. Gaolatle, Ignatius, Kumo, Kuili, Dr. Mabunu, Dr. Khan, Moseme, Santos is back with a Mac. All right, Brother Ryan, are you well? Awesome. AWOL. Nah, nah, nah. If that happens, I'm just hoping that you are still able to start and push. So yeah, colleagues, nothing much except that this is a master class. We always expect that it will be a high yield event, a little bit of some good information. Please pace yourself, have some coffee with you. We will take breaks in between. And from the administrative side of things, just to say that you will get your CPD certificates, we will report to the council, and also you'll have access to the self-paced version of this course, either for revision or if it happens that maybe your day is interrupted and you are not able to complete. But I just wanted to say thank you very much for continuing to trust us with your continuing educational development or professional development, as we call it. Yeah, we don't take it for granted. We know that it's difficult and it's a huge investment as well in terms of your finances. So we really, really want to appreciate you. Yeah, but these things are not possible without partnerships, without collaboration. So I also want to thank God for this impactful collaboration we have with Dr. Ryan Swepesat, and may he help us to continue to be able to do more and more impactful programs, because through these programs we touch so many patients, through your hands, so we really want to continue doing this awesome work. I think that in life you must give more than you take. You must touch people's hearts before you ask for their hand. So we are just here to add value in your lives and make you to really feel good about this career that you have chosen. I know there's many things that are going on with our careers. They're from government trying to cut off overtime, medical aids not paying our private practitioners. There's so many things in healthcare. But we must remember that beyond the professionalization of this work, it's God's calling. We are called to serve people when they need us the most. Even the richest person, at some point, they're gonna need to come to healthcare. So yeah, thank you, and thanks again, Brother Ryan. I know it's a speech, but I was hoping 5 more people will join. But I think we should start. Let me hand over to you. I think people will join as we go. Thank you. Yeah. 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 No, what we must request, Brother Ryan, is feedback from those who wrote so that we can know what we need to talk more about and emphasize, etc., etc. But yeah, I will reach out to I can't tell exactly who wrote, but I think I'll just just do a survey and see who responds. Yeah, thanks.
And then part 2 is all about theory. Now, theory, I have a truckload of information. It is not possible to cover all the theory today. So what we're going to do is we're going to do part 1, then we're going to break into theory for probably about maybe 3 hours, 3.5 hours, then take a lunch break. We'll come back for the OSCE, the SOE, and then try and cover the balance of whatever theory we have outstanding right at the end. And whatever is not covered in the theory, I will I will record some videos, and you can do that self-paced, okay? Because there's just too much of theory, as is with all the disciplines, really. And of course, I got some dad jokes in between to keep it kind of fresh and exciting. Okay, so Brother Muela, how many people do we have? We have 13 people here. Are we ready to go? Give me a thumbs up if you guys are ready to go. You got your coffee, you got your snacks. Yes, gastroenterology. We're keeping our tummies happy today while studying the tummy. Okay, guys, let's break into common exam scripts. Okay, here we go. So what you know what? Feel free to type in the chat box while I read the vignette, because more often than not, you probably have an inkling as to what the diagnosis is. Okay, so middle-aged male this time with a history of heavy tobacco and alcohol use, presents with a rapidly progressive weight loss. Difficulty swallowing solids and now liquids. So note that it is progressively worsening. Solids and now liquids. Retrosternal chest pain, and he has a diminished hemoglobin and a diminished hematocrit. So what's the diagnosis and what is it due to? Can we have some takers in the house? Some submissions here. Okay, chat box is empty. I'll say morning. Feel free to provide some answers. Yeah, any takers here? Oh, Santos says esophageal cancer. Nice one.
Morning.
Morning,
I
Santos.
ask you a question.
Okay, Mosemi says esophageal
Do I
cancer.
want mic because
Yes, I think that's a good place to start. Thank you so much for those submissions. Let's talk through the script a bit. Some pointers to help us. So you know that you got to mind yourself that progressive dysphagia
I can't sell
for
it.
solids and
on
then
the
liquids
PC.
speaks to a
You must
mechanical
give them
problem.
to me,
Okay, and
Papa.
more often than not, it's
Laptop.
I beg your pardon. If you have dysphagia to solids equally to liquids, it's going to be a motility problem. They're thinking about achalasia or scleroderma. But progressive dysphagia for solids and then later liquids equals to a structural problem, which you're thinking can be cancer, can be a stricture.
We'll
But
talk.
intermittent dysphagia to solids and liquids comes and goes, not there all the
In the
time.
meantime,
Intermittent,
ask Mom
that
for the
speaks to
password
a
for this
web
thing
or an esophageal ring.
so that
Okay.
you can
Now
practice.
remember that there are two kinds of esophageal cancer. Now, patients who smoke and drink heavily are at risk for squamous cell cancer, as in this script. The script for adenocarcinoma would include a middle-aged male with a long history of gastroesophageal reflux disease with or without Barrett's. Okay. How do you diagnose this, guys? Clinically, and also you need to do a barium swallow and consider endoscopy with biopsy, and then you go on to staging. Okay, TNM staging. And how do you treat this? Obviously, combination chemotherapy, radiotherapy, together with surgical resection. Okay. Now, very important point, guys, sites for metastasis. Where does esophageal cancer like metastasize to? Well, if it's adenocarcinoma, it likes to go to the liver. But if it's squamous cell carcinoma, it likes to go to the lungs, bones, and adrenals. So basically, liver, lungs, bones, adrenals. Liver, lung, bones, adrenals. Prognosis obviously depends on the histology, number one. Number two, the depth. Number three, the size of the tumor and the existence of metastatic lesions, okay? So well done, dysphagia due to malignancy. That was our first script. Going on to the second script, male patient, age 20 to 35, so young male with a history of inhalant allergies. This is very important. Wheezing and chronic rhinitis, so a lot of hypersensitivity going on. Presents with several years of dysphagia and a history of food impaction. Retrosternal burning, occasional regurgitation of acidic contents. He may have a normal white cell count, but if we do a differential on that, you find that he has eosinophilia. And if you do immunoglobulin levels, he will have a raised IgE. And the upper scope shows you multiple mucosal ring. Okay, what do you think about this, guys? So Dr. Vela says achalasia. I'm not sure if you're responding to this one or the previous one. I'll give you guys maybe 10 seconds or so to consolidate your thoughts about this one. Right, young male, hypersensitivity, okay, food impaction, eosinophilia, raised IgE, multiple mucosal rings. What's your thoughts, guys? Okay, I see. Okay, let's just head into the answer. The answer here, guys, is eosinophilic esophagitis. Okay. What's your clues here, guys? It's a young male, first up. History of atopy is your second clue. And this, I think I have a slide in the theory. We'll talk about so-called circularization of the esophagus, which is a big seller for this diagnosis with linear furrowing. Now, peripheral eosinophilia is seen in upwards of 30% of these patients. So don't be dissuaded from the diagnosis if eosinophils aren't really part of the clinical scenario. Okay, how do you diagnose this clinically and with endoscopy and with biopsies? And biopsies will obviously show eosinophilic infiltration. How do you treat eosinophilic esophagitis? Well, elimination diet based on the patient's own allergens. And often you might want to consult an allergist, okay? And you may want to think about topical glucocorticoids, and then we have swallowed fluticasone together with the PPI. And if you have any esophageal rings, you want to dilate those via scope. All righty. Okay, let's talk about more. Healthy patient, healthy patient. Nice to have healthy patients. Presents with intermittent retrosternal burning, regurgitation of acidic material, sensation of a chronic lump in the throat. Doc, I always have this lump in my throat, sensation of like a lump, you know, and repetitive throat clearing. Okay, any takers on that one? Oh, thank you. I see that I had 2 contributions for eosinophilic esophagitis. Thank you for that, guys. This one? I think it's a relatively healthy patient. Okay, so Dr. Mazi says good. All right. I'm not sure if you guys are in concurrence with this being good. Yeah, it does sound like good, doesn't it? Any other contributions, guys? Let's head on to the answer. Excellent. Good. Gastroesophageal reflux disease. Okay. Now, not all patients have burning and regurgitation symptoms. Some may only have the globus. So when they describe chronic lump in the throat, that's what we call a globus sensation. And cough with bronchospasm and hoarseness can occur. How do you diagnose this, guys? It's clinical and endoscopy with biopsies if symptoms fail to respond to PPIs. And when symptoms are worrisome, such as odynophagia, if you have concomitant alarm symptoms, so GI bleed, weight loss, anemia, and you may want to consider a right upper quadrant ultrasound to exclude biliary tract disease if nausea and epigastric pain are present, okay? How do you treat this? Lifestyle changes, we'll talk about that in the theory. Antacids, you may consider PPI. Some people like H2 receptor antagonists, okay, but PPI is probably the better choice nowadays. H2 receptor antagonists don't have a very favorable side effect profile, so PPIs are the way to go. Proton pump inhibitors, right? PPI. Okay, how about this one? Caucasian patient. Now, whenever they say Caucasian, you think about specific genetic issues, okay? Whenever they give you in the STEM location, that speaks to probably an infectious problem that's common in a specific location. And whenever they give you the race of the patient or the ethnicity of the patient, you're thinking about genetic issues, okay? So Caucasian patient older than 50 years, so not a youngster, presents with a long history of retrosternal burning, all right? Sensation of a chronic lump in the throat. Okay, that's globus sensation, thank you. Repetitive throat clearing, okay. Sounds like the previous vignette, doesn't it? There's a bit of a twist here. And the upper scope shows you a velvety red columnar epithelium in the distal esophagus. Ooh, what is that? Biopsy of columnar epithelium shows you intestinal metaplasia. Now, this is a very specific concept we're trying to test here. Does anybody know what we're talking about here? Okay, so Mosomi and Ignatius say reflux esophagitis. I think that's in reference to the previous question, maybe. So intestinal metaplasia, guys. Thank you, Dr. Mutledi. Sorry, my pronunciation is bad. Thank you, Doc. Barrett's esophagus is where we're going with this. Barrett's esophagus. What is Barrett's esophagus? The presence of columnar epithelium in an area where it should not be, right? And specialized intestinal metaplasia. So normally, you should be looking at, in the distal third of the esophagus, you should be looking at normal esophageal squamous mucosa. But when you have metaplasia of this and becomes columnar epithelium, that is what we call Barrett's esophagus, right? How do you diagnose it? Clinical and with endoscopy, with biopsies. And in terms of, so it's a big topic about, okay, fine, you found Barrett's. What is your surveillance endoscopy? How often are you going to do surveillance? So according to the American Gastroenterology Association 2011 guideline, recommend surveillance endoscopy with biopsies with interval determined by the histology and endoscopic eradication of existing dysplastic areas with PPI. So we'll talk about that later. We'll talk about screening and surveillance, etc., a bit later in the theory, right? So this is just to recognize that long-standing gastroesophageal reflux disease can cause intestinal metaplasia in the distal esophagus, which is what we call Barrett's esophagus, and this is a pre-malignant lesion. Okay. How about this one? Otherwise healthy, older than 45 years, presents with several weeks of epigastric, so-called hunger type pain, which wakes the patient from sleep. So anything that wakes the patient from sleep cannot be physiological. It must be pathological. So that is a marker of severity. And it occurs about 3 hours after meals, but is relieved with antacids or with eating. Epigastric tenderness, okay, no weight loss, very important, no weight loss, no vomiting. Barium swallow shows well demarcated center in the duodenal bulb. What on earth is this? Hunger type pain, guys. It wakes the patient from sleep. What's your thoughts about this, everybody? Given the information in the vignette. Thank you, Dr. Matladi. Duodenal ulcer. Well done. Duodenal ulcer. Duodenal ulcer likely due to H. pylori. Okay, so let's talk about this. Helicobacter pylori is the traditional cause of ulcers in the duodenum. Non-steroidals are also a very important other risk factor. The tricky part of evaluating dyspepsia is that clinical symptoms cannot reliably distinguish who has an ulcer and who doesn't. So when the patient comes in saying, Doc, I have hunger type pain, I have epigastric tenderness, you can't really tell whether it's a gastric or a duodenal ulcer usually. There are some other pointers, we'll talk about it later, but usually a workup for this sort of dyspepsia is only done in a patient who is older than 45 years of age or has worrisome signs such as anemia or weight loss. So how do we diagnose this, guys? Clinical and with H. pylori testing, which can be in the way of a urease breath test. It can be in terms of a stool antigen. Okay, 2 negative tests would exclude it. If young and without worrisome signs or symptoms, or endoscopy with biopsies and urease testing if older, with risk factors for malignancy or with worrisome signs and symptoms, or if using PPI for any treatment, you want to wean down the dose to prevent hypersecretion after discontinuation, okay? So basically, how do you treat this? Okay, so you're going to give H. pylori, you're going to give eradication therapy, which is PPI with 2 antibiotics. We'll talk about it later. Nice. Okay. As you know, we're still on the upper GI tract here. Patient presents with a several year, oh dear, it's a chronic problem. History of progressive difficulty swallowing solids, difficulty swallowing liquids, difficulty initiating a burp. And the medical term for burp is eructation. Eructation. Okay, burp. Weight loss of 5 to 10 pounds. Okay, fine. That's significant. Intermittent chest pain, and aha, look at this. Barium swallow shows peak-like narrowing. This is a big buzzword. Peak-like narrowing. What's the diagnosis, everybody? Any takers in the house for this one? Sounds like a motility problem. Okay. Okay, Ignatius saying gastric outlet obstruction. Okay. Ignatius, all right. But remember, does that give you beak-like narrowing on a barium swallow? Okay. And this sounds like difficulty swallowing solids and liquids equally. There's no progression in terms of solids first and then liquids. So that speaks against the structural issue. Right. Okay. Okay. Let's have a look at the answer, guys. The answer is going to be achalasia. Okay. Now, if you don't recognize any of the other features here, dysphagia with liquids is a very big clue. Always think about achalasia when you see that. It happens also with systemic sclerosis as well, but this script does not present any other features which suggest systemic sclerosis. Now, progressive dysphagia to solids and liquids equals achalasia or scleroderma, but progressive dysphagia to solids first and then liquids equals a structural problem like a cancer or a stricture. And we said intermittent dysphagia equals either a web or a ring. Okay. So how are you going to treat achalasia? So basically, we'll talk about it in the theory, guys. I don't want to talk too much about the conditions now. This is just, recognition from the clinical scenario. But you treat it with nitrates, calcium channel blockers. Maybe you want to dilate the lower esophageal sphincter. You can do Botox injections into the lower esophageal sphincter. because there's a failure of the lower esophageal sphincter to relax, isn't it? That's the problem with achalasia. And surgical myomectomy as a last resort for refractory symptoms. Okay, middle-aged male presents with long history of intermittent rectosternal burning, occasional regurgitation of acidic material, develops gradual but progressive, difficulty swallowing solids, then liquids. Okay. Right, so they're not giving any alarm symptoms really. He's not losing weight, he's not having anemia. Okay, any thoughts about this one, guys? Any thoughts about this one? Okay, yeah, esophageal stricture. Esophageal stricture is the way to go. Dr. Matnadi is on fire today. Okay, peptic or benign esophageal stricture. What are the clues here, guys? The history of gastroesophageal reflux disease preceding the dysphagia is your clue in this vignette. Okay, remind yourself that progressive dysphagia to solids and liquids, once again, equals achalasia or scleroderma. Progressive dysphagia to solids first, then liquids is going to be a structural problem, being cancer or stricture. Intermittent dysphagia to solids equals webs or rings. Okay, how do you diagnose this? Clinical and endoscopy. You may consider a barium swallow if you need to exclude achalasia. And you treat with esophageal dilation. The only way to treat a peptic stricture is to dilate it with the endoscope. Okay. How about this one? Young patient presents with recurrent episodes of acute chest pain after ingesting cold liquid. Now, note what they're telling you, right? Young patients ingesting cold liquids. What's going on with the cold liquid that's causing this pain? Recurrent episodes of difficulty swallowing. Episodes, comes and goes. Negative cardiac stress test. You thought it was a cardiac etiology, and guys, many at times a differential for retrosternal chest pain. Obviously, you need to exclude cardiac because that's the most life-threatening one. Then you think about esophagus and stomach, okay? And you also think about musculoskeletal, right? Those are the most common causes of chest pain. And look, very specific pattern here. Barium swallow shows you a corkscrew pattern. Corkscrew in a young patient after drinking cold fluids. What do you think about this, guys? So, Dr. Moseme, I think there was a previous question that was correct. Nice one. In this question, the youngster with the corkscrew esophagus and chest pain after ingesting cold liquids. Do we have any takers in the house? Going once, going twice, going once, going twice? No. Diffuse esophageal spasm. Okay. Now the buzzwords here: number one is a young patient. Number two, cold liquids. Number three, corkscrew. Right? Young patient, cold liquids, corkscrew. Young patient, cold liquids, corkscrew equals diffuse esophageal spasm. How do you diagnose this, guys? With this clinical history, you want to also consider manometry, which is going to show you excess simultaneous contractions, and the barium swallow. And I think the big seller here is the barium swallow, showing you the so-called corkscrew pattern. How do you treat this? Well, there's numerous pharmacological options, including diltiazem. If you guys remember diltiazem, it's a non-dihydropyridine calcium channel blocker. Diltiazem we often use in setting of arrhythmias. Okay, it's one of the options for atrial fibrillation, actually. Okay, trazodone, imipramine, sildenafil, botulinum toxin, others. Non-pharmacological approaches include ingestion of hot liquids and peppermint oil. So peppermint oil actually relaxes the lower esophageal sphincter, and actually predisposes to reflux. But in the setting of diffuse esophageal spasm, it's to cause relaxation of that smooth muscle, which is exactly what you want. Okay. Patient now presents with years of intermittent difficulty swallowing solids, especially chicken or bread. Then KFC, Nando's, what we eating today, guys? Often relieved with regurgitation or changing position. No weight loss, no anemia. Okay, fine. Good. What's the diagnosis, guys? Any thoughts about this one? Intermittent is the keyword. They're intermittent difficulty. So it's not constant, it's not progressive, it's intermittent. Anybody in the house? Anybody in the house? Nobody in the house. This is a weird one. It's dysphagia due to what we call a Shatsky ring. Shatsky ring. Now, the key thing, guys, is the intermittent nature of the presentation is an important clinical clue. Rings and webs are more often intermittent and non-progressive, while cancers, strictures, achalasia cause progressive dysphagia. Remind yourself, once again, guys, progressive dysphagia to solids and liquids together equals achalasia or scleroderma. Progressive dysphagia to solids first, then liquids thereafter equals cancer or stricture. Intermittent dysphagia to solids equals webs or rings. So this is a ring, Shatsky ring. How do you diagnose it clinically? You may use endoscopy and barium swallow to exclude achalasia. And how do you treat it? Esophageal dilatation via an upper scope. Okay. Right, this is a weird one. Look at this one. A teen patient on oral doxycycline for chronic treatment of acne presents with acute onset of pain with swallowing and external pain. Okay, so I'll leave it open for a couple of seconds for you guys to suggest what's happening. Right. I see the submissions have dried up a bit. Let's have a look. This is called pill-induced esophagitis, okay? Now, what are your clues here, guys? Doxycycline is famous for causing esophagitis, especially when the patient takes the pill at night without water. And other notable drugs that can cause esophagitis include aspirin, potassium supplements, over-the-counter quinidine, often taken for leg cramps, iron supplementation, and alendronate. Alendronate, as you remember, guys, from endocrine, when we covered osteoporosis, is a bisphosphonate, okay? The risk is increased if the drug is taken at bedtime and without water. How do you diagnose? Clinical and endoscopy. If you need to exclude other causes of dysphagia because of the patient's risk profile. How do you treat this? Simply discontinue the pill and substitute with a liquid preparation. Okay,